time I knew what happiness was, let the memory live again. Every street lamp seems to beat a face.
Welcome to the 2012 Alzheimer's Symposium. Thank you for joining us today. My name is Pauline Polanco, and this is Rita Williams. We are the co-chairs of the Victoria Planning Committee, and we, in conjunction with the Alzheimer's Association and the UT Health Science Center in San Antonio, have made this education opportunity possible for you. Even though we will individually introduce our committee to you during our lunch break, we would like the Planning Committee and our San Antonio partners to stand at this time so you know who they are. And there's people that aren't in here. But yes, they're still working. I'd also like to thank Elmcroft Assisted Living for our breakfast this morning. Today we have very talented speakers who are experts in the field of Alzheimer's education and research. We are honored that they have given their time to us today. The format of their presentations will be 45 minutes of uninterrupted presentation and education, and then 15 minutes of question and answer. So if y'all hold your questions or write them down, we hope that we've inundated you with notepads and pens in your little goodie bags. And if you could just write your questions down, we'll address them in the last 15 minutes of their presentation. And I'll give it to Rita.
Good morning. I don't know about y'all, but I live in the boonies, and it took me forever to get here today. It took forever. Well, good morning. Thank y'all again so much for joining us today. Our first topic is local resources to assist in the care of Alzheimer's disease by Robert Mailer, RN. Robert Mailer was the Assistant Director of Nursing for Regional Correctional Psychiatric Hospital and the American Correctional Association National Auditor from 1999 through 2004. He is also co-author of a bioterrorism awareness continuing education program. Robert currently serves as Director of Mental Health for DTAR Healthcare System's 8-bed Geriatric Mental Health Center. We welcome our speaker, Mr. Robert Mailer.
Alzheimer's is a disease as well as a life journey. As all life journeys go, they have a beginning and an end. I want all of us to take a second and consider your life is changed by Alzheimer's. Your life as you know it is a new beginning every time that you wake up. Every morning is a new day. The faces that you see, the family, the spouse, the children, you no longer recognize. The people that are in your life, lifelong friends, you no longer recognize. You have new healthcare workers that come to your home or that you have to go to the office to see. You go to the hospital or are inundated with people that you don't know. The fear, the anxiety, the change. Many of the patients that we see them in their worst. At a time when the anxiety is high, the fear level is high. And we see them when they act out, when they're angry, when they're agitated, when they're aggressive. And many times we wonder, why are they acting this way? Why are they becoming these people? Why the change? And we turn off the lights to kind of give an overshadow of what it feels like with Alzheimer's, the darkness, the despair, the loneliness, the depression. And with most of the people with Alzheimer's, they slowly fade away into themselves, and many of them attempt suicide or are successful in suicide. In my presentation today, we are talking about resources. And in the Alzheimer's world, a resource can be a light in the darkness of their everyday life. A series of lights that light up their life to brighten it a little brighter, to make things a little better, not only for the patient, but for the family members that are dealing with the change and the loss and the enveloping gloom of the disease. When these patients come to us one at a time, they may start with a primary care physician. They may start with family members that notice the change in that individual. They may start with a local pastor at a church that notices something is going on, refers them for help. But somewhere along the line, someone takes notice and they get the help that they are so badly needing. And with that start, with that initial resource, other resources come into play. And along that line of resources, each light is turned on, and their life is given a little bit more light, and it becomes a little bit more brighter, and the families are given the support that they need. And in this representation, as you can see, this room started off very dark, very bleak, very bland, and as each individual is able to turn on their light, it changes the whole view of this room and lights up the faces and the overall appearance of this room. And that's what this representation of this presentation I want to be for each of us, is to see that if we each turn off on our light, we can light up an entire world. And by doing that, one light leads to the lighting up of an entire world for the recognition and the support of Alzheimer's patients. Y'all can turn off those lights. Good morning. It was a real pleasure for them to come and ask me to be one of the presenters here today. I moved to Victoria about 2 years ago from right outside of San Antonio. I'd been to Victoria before. My history in psychiatric care was in the correctional system. So as you can imagine, I didn't ever worry much about resources. Everything we had was basically within chain link fences. So when I came to Victoria and I started learning about resources here, the one thing I found pretty much immediately was the lack thereof. Psychiatrists, and for the majority, there's not a lot of psychiatric specialists in this area unless you go to Houston, Corpus, San Antonio. And hopefully we're on the verge of making that a better situation and getting resources here for these patients. The first thing I want to cover is just a basic background, demographics of what we're dealing with as a nation as far as Alzheimer's, the aging demographic, and how this is changing over time. The psychosocial issues of aging, caregiver issues, and caring for the caregiver as well as the patient. As far as demographics, demographics are changing the shape of our society as a whole. As you know, the aging population is the most populous amount of our population. They're the largest demographic and is continuing to be so. All the baby boomers are ages 50 to 65 at this time. They're the fastest growing segment of our population is the 65 and older. Of the 65 plus, 85 years and older are the fastest growing segment of that population. And if you look at this slide, you can see that as a whole, the population in America is going to continue to grow faster and faster until they're predicting in 2040 we'll have nearly 70 million people in the US. And the majority of those people will be older than 65. Just a little insert. Women live longer. The life expectancy has increased since the end of the Great Depression, but women are expected to live longer than men and usually do. Males born in 1950, life expectancy is 77, whereas a woman born in 1950 is expected to live to the age of 83. I had a really good friend of mine when I was putting this presentation the first time, and he said, you know, the reason that is women can take care of themselves better than men can if they're left alone. So that could be the reason that is. Ratio of men to women. At age 65, there are 68 men for every 100 women. And at age 85, there are 45 men to every 100 women. One of the key issues when we talk about Alzheimer's aging disease processes is where these individuals are living, what their living conditions are like, the access to treatment and care that they have. And the one thing that we found in research, especially in this area, which I've learned, is most of these people, age 65 and older, are living either alone at home with a spouse, or with family. And one concern in this area is the ones that live alone at home, or live at home alone with a spouse. So many times with mental health, I know that I go to different presentations, I have different booths, and we put up our big DTAR Geriatric Mental Health Center, we put up the Alzheimer's banners, we put up dementia, depression. People see our banner and keep walking. And it's no different from those patients that are sitting at home. The last thing you want to admit to yourself is that you have a mental health issue, because there's such a stigma with that classification. I'm not depressed, I don't have Alzheimer's, I don't have dementia, I'm okay, and people are going to take care of me. Or the wife that's caring for the husband is, I will take care of him. I'm not putting him in a nursing home, I'm not putting my mom in a nursing home, and the stigma there is very hard. They also live with non-relatives in certain situations, or they live in long-term assisted living, which we're going to touch on just a little bit later. As you can see in this presentation, men and women are a little bit different because there are more women than men at this age. Most men live either with a spouse, or very few live alone or in an assisted living or long-term care facility. Women, on the other hand, they either live alone or with a spouse. Pretty evenly matched, and then a little bit less live in a long-term care facility or assisted living. Alzheimer's disease statistics, there are approximately 5.4 million Americans with Alzheimer's, 5.2 million of those being 65 and older. About 200,000 of those are under the age of 65. It affects 1 in 8 Americans. It's the 6th leading cause of death in the United States. There are over 15 million Americans that provide unpaid care for Alzheimer's and dementia. And I don't know, I'm sure that most of you in this room are healthcare providers. We deal with dementia, Alzheimer's patients on a daily, regular basis. I cannot imagine dealing with this process with a family member at home. And the difficulty that we have, we can displace ourselves a little bit because we're not family. And we can go home at night. But the caregivers that take care of these individuals at home, they have nowhere to go. They are home 24 hours a day, and unless they know the resources that are available to them, they have nowhere to get away to. They have nowhere to go. They have no assistance. Approximately 800,000 of them live alone, and in this situation, it's even worse. These people are alone. They begin to wonder as their minds continue to deteriorate. We find that the police have to get involved because they're wandering out in the streets. They become aggressive, agitated, and we see the symptoms that we see when we get them, which is way late in the process. And if we had seen them or gotten them into the system earlier, there are things that we could do to perhaps delay, prolong, or assist the family and the patient in getting the help they need. It costs about $200 billion in U.S. care costs just in 2012 for the care of the Alzheimer's patients. In this presentation, you can see the prevalence of Alzheimer's disease in age. From the under 65 is only 4% of the population. 6% of them are 65 to 74 years old. From 75 to 84, 44%, and the 46% of those over age 85. The one thing I do want to touch on in this is, in most cases when we get these patients from the 65 and older, you're dealing with medical issues as well as mental health issues. And we see this in our care and practice on a daily basis. Those with dialysis, and differentiating the difference between a patient whose ammonia level is high or sodium levels are off. Is it a medical issue that's caused the delirium, that's caused the altered mental status, or is it actual Alzheimer's? And the testing that can be done and the CT scans, the head CT scans and the scanning and the tests that we perform allow us to differentiate the difference, which is why we're talking about resources and getting them where they need to go. Mental illness warning signs. The first and most important thing in resources to me is family. They're the ones that interact with these patients on a daily basis. They're the ones that see these patients and that need to know the resources that they can get them to. But the most valuable resource is family. I don't know, most of you probably don't know this, but my mother is sitting in this room today. And I would hope that me or my sisters, one of us, if my mom began to have symptoms of something going on, that we would recognize and get her where she needed to go. But in the statistics that we've shown, a lot of these people live alone. Most of them don't have family, some of them don't have friends. The neighbors, they're cooped up in their house, and as they slowly lose the ability to, or their mental function, they lock themselves inside. So the people don't see them. They don't know the risks of putting themselves inside the home. But warning signs that we are looking for are change in thinking, mood, and behavior, the confusion, the poor concentration, the indecision, and the wandering, the depression, the apathy, sleeping pattern changes, anxiety, fear, withdrawal, inappropriate emotional responses, feelings of losing control, addiction to chemicals, people, or events, thinking or talking about suicide, delusions and hallucinations, violence, and illegal substance abuse and alcoholism. The one thing that most people don't realize is the importance before anyone gets to the point of having Alzheimer's or a mental disease is the preparation not only for themselves, for their own care, but the care of themselves so the family is relieved of that stress. Most people don't realize that there is a psychiatric advance directive. Most people have heard of a medical power of attorney, a durable power of attorney, advance directives. There is such thing called a psychiatric advance directive. I have copies of this at our table, the DTAR table. It actually differentiates 3 different things for people before they ever get Alzheimer's. It's valid for 3 years. It creates a declaration of mental health treatment and addresses 3 topics. The use of psychoactive medication, the use of convulsive therapy or ECT. I'm sure most of you have heard of this in the history of psychiatric care. Everybody's scared that they're going to go and get head shocks. That's what we hear patients come in, are y'all going to shock me? Is this what's going to happen? Emergency mental health treatment. It addresses all of these issues. And I highly encourage us as resources to let patients and families know that this is an option as well as the legal forms that they normally fill out. Because if they do have mental health issues, a normal power of attorney is not legal. It's not a legal form when it comes to mental illness. This is the only form that counts. It must be signed by 2 competent adult witnesses that are not associated with their medical care, appoints an agent or makes advance instructions, and it's invalid in emergencies and involuntary commitments, which we're going to talk about in just a minute. And it's not the same as a durable medical power of attorney. Also, just a normal living will. I'm sure that most of us remember the Terry Schiavo case that happened in Florida, where the woman, her husband was fighting to have her removed from the machines. The mother and father were fighting to have her left on the machines. The decision was finally made in the courts to have her removed. The struggle went on for 3 years. And she laid there in a bed on tubes. And if she would just have had a living will, where she would have declared what she wanted done in the case that she was incapacitated, that decision would have been made immediately. I encourage everyone in this room, and as well as resources to families and patients, have them develop a living will so that we know when they come to us what their wishes for their life are. Power of attorney. There are three major types of power of attorney: a general, a medical, and a durable. And you can have one of each. A general power of attorney gives somebody the legal right to take care of your finances. A medical power of attorney allows someone to take care of your medical decisions. Do you want to be on a ventilator? Do you want to have emergency life-saving things done to you? And those decisions need to be outlined in the power of attorney. You can also have a durable power of attorney, which basically means that you can have the financial and medical side taken care of by the same person. Financial resources, having things in line. We have financial advisors that can advise you on retirement, terminal illness preparation, lawyers, last will and testaments, gifting, estate planning. Some people choose no planning at all. My concern with this is, and during this presentation preparation, I learned a lot about the state of Texas and its laws. If you do not have a state will, or a will, testament, last will and testament, the state inheritance laws go into effect, and basically the government disperses your assets as deemed necessary by them. And the one clause in the legal writing, which I thought was really funny in this whole thing, it says, this may or may not meet the requirements or decisions of the individual. And which is very true. If you leave it up to the government, they're going to do what they see fit. Early onset resources. Like I said, the first and most important is probably family and friends. Second is primary care physicians. We want to encourage all of our patients to get at least an annual checkup where the physician can assess them, see what's going on, do a mini mental exam, see how their process is going, and see if there is any symptoms of dementia or Alzheimer's. They can then get neurology consults and psychiatric consults. There was no way in the world I was going to be able to list all the references and resources for all of these. So what I've done is I've put together a packet of all the resources in this area. For psychiatrists, there is a list of all of the different psychologists, support groups in this area. They're also back there on the DTAR table. So those are all available to you, and it's a very, very deep list of everything that's available in the whole surrounding area. Acute care resources. From where I sit, most patients, families, or the individual sees that there's a problem, and either the police get involved or the patient goes to the emergency room because there's something wrong, something medically wrong. The patient's acting different, they're mentally different, somebody recognizes that something's wrong, and so they're taken to the emergency room. With Citizens ER and the DTAR 2 ERs, we get a lot of referrals for mental health and psychosis and Alzheimer's type patients. Law enforcement is very heavily involved, especially whenever the Alzheimer's patients deteriorate to the point where they become aggressive, agitated. The primary care physicians also are the ones that assess these patients, where we're encouraging the annual assessments. Gulf Bend is a great resource, and we're going to talk about them a little bit more in just a minute. And we have inpatient psychiatric units, which we'll discuss in just a second. Gulf Bend, their target population is for the indigent, Medicaid only, usually, population, no insurance. They typically deal with schizophrenia, bipolar, and depression patients. They do have counseling and different groups for schizophrenia, for patients, and for family support groups. And in that list, their contact numbers and all the information for them is in there as well. Their services, they do initial assessments, screening and crisis response, especially for drug and alcohol, in-homes, family support, and they do inpatient transfers, admission assistance. We deal with Gulf Bend regularly, especially when patients come to our emergency room. We have to refer them out. They're a great resource for finding outlying inpatient facilities and beds for our patients. Whenever they come to the emergency room, we have to transfer them because we don't have a bed available or we can't provide the services needed for those individuals. The DTAR North Geriatric Health Center, also referred to as the GMHC, that is the department that I'm the director of. We take patients that are 60 and older. We are currently an 8-bed unit. We are expanding 12 additional beds. It will be opened in February 1st. The average length of stay is 10 to 15 days. I will tell you now, when I say an average of 10 to 15 days, we have some patients that stay 30, 35 days, depending on the necessity of the patient. We treat all Axis 1 diagnosis, including depression, anxiety, post-traumatic stress disorder, Alzheimer's, dementia, psychosis, bipolar. We also do medication management. The one key thing I do want to express again is the lack of psychiatric assistance in this region. We have primary care physicians attempting to regulate psychiatric medication, and it's not working very well. We get a lot of referrals directly from primary care physicians saying, we don't know what to do. We've tried multiple medications, we've tried this regimen of medications, we need a psychiatrist to look at it. So we do a lot of medication management for PCPs on our unit. We do not do any drug or alcohol detoxification at all. Those have to be referred out. It's a special program that requires special needs that we do not have. Admission requirements for the Geriatric Mental Health Center, they have to have a valid Axis 1 diagnosis. I do want to express, though, they do not have to have one prior to coming to us. When they come to the emergency room, the physician can give us a detailed assessment criteria, and our psychiatrist can accept them based upon that criteria, not an existing diagnosis. So that can be misleading at times if people's like, well, I've never been to the doctor, I don't have a diagnosis, I can't go. That's not true. Based upon the assessment criteria and the assessment data that the physician gives us, we can deem a determination until further inspected and assessed by our psychiatrist. The geriatric patient must be 60 years or older and must be medically stable, able to participate in programming. They come in either on a voluntary or involuntary status, which I will talk about in a minute. We also give them a mini mental exam, which I will discuss, and they may not be signed in by another person. In the past, if I was married and my wife had Alzheimer's or she had a mental breakdown psychotic episode, I could take her in and have her committed to a psychiatric unit for her health care, especially if I was her power of attorney, medical power of attorney. You can no longer do that. It's illegal in the state of Texas. It's considered imprisonment. And we're going to talk about a little bit of the history of that in just a second. GMHC services, the services we provide 24-hour monitoring and supervision, diagnostic assessment and evaluations, one-on-one visits with a psychiatrist. They're seen by the psychiatrist every day. They have a one-to-one with the psychiatrist and the social worker on a daily basis. We do medication stabilization and management, group therapies, multiple group therapies of different sources for each individual patient. Secondary medical issue management. If the patient has other medical issues, we will address those. We have some patients that come in with a mental health issue. It turns out to be a delirium caused by a medical issue. We will then treat them for that. So we can address it across the board. Patient and family education and discharge and aftercare planning. This is probably the most intense part of what we do. The everyday care of the mental health patient is very simplistic and easy for us to do because it's on an everyday basis. It's when we start planning for those patients to go somewhere else, and that's where the resources come in for us. Most of you in here, I either know of you or I've talked to you in person or on the phone. You send us referrals. We also send them back to you. This is a very difficult time for those patients that have been home alone or for those patients that have been home with family, because the families feel like they're dumping them in a nursing home. They feel like they're putting them in an assisted living when they want to be home, and the patients are adamant that they want to go home. But we also have to look at what the best interest and what the best prognosis for that patient would be. And some of these patients with wandering and with the late stages of Alzheimer's, the safety issue for going home it won't allow for that. And so I just want to say thank you for y'all's assistance and for y'all coming up and looking at our patients whenever y'all come up there. Voluntary versus involuntary inpatient admission status. This is a major key issue that we've had a major change in over the last probably 10 years in mental health. The voluntary patient is relatively easy. They come in, they're referred to an inpatient psych facility. We give them a mini mental exam, which is a 30-point exam. We ask them basic information like what's today's date, who are you, where are you coming from, can you spell the word world backwards? They look at us like we're stupid. We ask them to draw little pictures. We ask them to write sentences, do basic fundamental mental health assessment tools. If they score 24 or higher on that, they can voluntarily sign themselves in if they're willing to come. So it's pretty easy for the voluntary patient. It gets a little bit edgy on the involuntary. And a lot of people don't understand this process totally yet, so I want to just cover this just for a second. If they score under 24 on a mini-mental exam, and let's say at a facility they are giving a mini-mental exam and they score above a 24 with you, but when they get to us they score below a 24, we are not going to go by the mini-mental exam that was administered before they came to us. We're going to go by the administration of the exam by the licensed professionals. If they have a diagnosis of dementia, they automatically have to have an involuntary admission. If they have become a risk to self or others, if the police have been called to the home and they are threatening suicide, threatening homicide, they some kind of physical act to themselves or someone else, they automatically are going to have an involuntary admission. The admission criteria is met, but they're unwilling to come, again, if they put themselves or somebody else at risk. It requires an emergency detention warrant, and the court becomes the guardian of that patient while they're in the inpatient facility. The involuntary process, the emergency detention warrant, the application is either made by the police officer, or when the patient comes to us, the facility referring, or the receiving facility, we go to the Justice of the Peace. The four of them for this county are listed there for the city of Victoria. The emergency detention warrant application is processed. It allows us to detain the person in a locked unit for 72 hours. During that 72 hours, the receiving facility, we then process paperwork. There's a psychiatric and medical assessment done, and other paperwork that is filed with the county court. Then they give us a 90-day hold on that patient, so we can treat and hold that patient, administer medications for 90 days without their consent. I do want to say, if the police are involved and this warrant is done, this is not a criminal case. It's a civil case, that's all it is. It's a legal means of administering medication to an individual that doesn't have the competency to authorize that treatment. It's no different than a patient walking into the emergency room having a heart attack that can't give the authorization to be treated. It's a given authorization. We go ahead and treat and we stabilize the patient. It's no different with mental health. There's a huge stigma for inpatient psychiatric facilities or for psych issues in general. The one key thing that I learned, I didn't even realize this, was mental illness is more common than cancer. What I find really funny about that is you don't hear about it. You don't read about it. You don't see pink bras for mental health. But cancer is everywhere. It's publicized, it's very common knowledge, it's all over the TV these days, but mental health is not. It has a stigma to it, nobody wants to talk about it, but the reality is it's going to get worse before it gets better because our aging population is growing, and mental health has to be observed and recognized and appreciated for what it is and treated. The psychiatric treatment in movies, if you've seen sci-fi thrillers where they go to the psych unit, you know the treatment that's given there, and if you take any belief in any of that, you don't want to go at all. Fear of being labeled crazy, insane, mental. Those patients that come to us, their first question usually is, so is everybody going to know I'm here? Is everybody going to know I'm crazy? We don't, and that's the key thing we want to let people know is that it is totally, completely off the books. We don't even register with them through the hospital. Nobody knows they're there. That their name is kept private, and the privacy issues are very, very valid on our floor. The fear of breaking confidentiality, the history of mental health institutions. The key aspect that I want to share with y'all most of all is the change in the law and the reason for it. Back in the 80s, early 80s, in Austin, a common practice was that there was a whole lot of homeless in Austin. So the key plan was we're going to clean up Austin. So they started rounding up the homeless and sticking them in mental health institutions. Against their will, there was nothing mentally, they had no mental health issues, or if they did, it wasn't to the capacity that they needed to be locked away. So they just started locking people up. And in the early 90s, they passed the law for involuntary admissions in the state of Texas. And so now the court becomes their guardian and can deem a person whether they belong or they don't belong in a mental institution and locked up. And that's why we have to go through the involuntary admission process. A history, especially in movies, of restraint, seclusion, forced medication, and electroconvulsive therapy, the ECTs. Other inpatient psychiatric programs in this area, also listed in the resource manual that I put together. Matagorda Regional Medical Center in Bay City, they have a 12-bed geri psych facility as well, and they take ages 55 and older. North Bay Hospital in Aransas Pass also has a 12-bed geriatric psych, ages 55 and older. And San Antonio State Hospital, and I will tell you now, especially this time of year, because of the holiday season, these hospitals are full. We try to refer to SASH on a regular basis, and we can't get a bed. And again, I resort back to why isn't mental health on every TV commercial and discussing it, because if the beds are full, there's something wrong. San Antonio State Hospital, they have multiple programs that we refer to. They have an adolescent unit, they have forensic units, and all this information is that book. But we use SASH basically for their geriatric mental health unit for all types of diagnosis. Homewood residents, once these patients go through an inpatient stabilization or they go to the hospital and they're not deemed able to go home, there are programs, and very, very good programs that I've learned about during my research for this program in this area. Homewood residents, their Clare Bridge program, they have a 19-bed facility, it's a private paid facility. It's a secured environment and programs for those with Alzheimer's and dementia. I didn't even know this place existed, I'll be really honest with you. Until I started doing this research, I found more resources in this area than I even knew existed. I actually went and took a tour of their facility. It's a very nice facility, very home-based. The patients have their individual apartments or semi-private apartments as well. And the one key thing that I saw in several of these locations that I went to visit, as well as in Port Lavaca, was they have these shadow boxes outside the rooms, where these people, these individuals, these patients, they can portray the lives, their history. And it's like a remembrance box. And when I saw these things, I was like, when they walk out of the rooms, they get this image of themselves before. And it was, I don't know, it did something to me, because I was like, wow, that's pretty deep. They have their room where they live now, but when they walk out and they walk out into the community area, there's this one last remembrance, or this remembrance of who they were before they came there. It was really, really, really good idea. I don't know who came up with that, but several facilities had that, and I was impressed with that. They have multiple care programs comprised in their Clare Bridge program. They have a daily path program, a dining program, a training program, and a behavioral problem-solving program. And I do know that she will be discussing some of those programs with you in a little while. I was going to go with that, but I know that my time is slipping away, so I'm going to let her take care of that. AllsCare Assisted Living. I know that AllsCare has two different facilities here in Victoria. One is dedicated specifically for early to mid-stage community home for early to mid-stage Alzheimer's, and one late middle to late stage community home, which was just, no, that's the new one, is the early to middle late mid-stage. Yeah, early to mid-stage. They just built, and we were at the grand opening of that very nice facility, and I got to tour the other facility not too long ago. Another great facility specifically for Alzheimer's patients. And they hold 16 residents in both those facilities. The Lighthouse at Trinity Shores is the other facility that I was just talking about that had the shadow boxes outside the rooms. They have a 13-bed secured unit. They care for early to late Alzheimer's. The one key thing I do want to express about several of these facilities is they aren't separated. And I was really impressed by that as well with the Lighthouse and with different programs, the Clare Bridge program. They have early all the way through late together. And it's really interesting to see these people interact with each other. They care for each other. They take ownership of each other. And I was really impressed and very impressed with the cleanliness and how well the programs were run for these individuals. Their daily program schedules promote socialization, physical activity, and community awareness. The one key thing about Lighthouse that I did not know was their Their patients must be independent or require less than 2 persons to qualify for admission, which most people do until late stages. Other facilities with secured units. Port Lavaca Nursing and Rehab has an 18-bed semi-private facility. Stevens Nursing Home in Hallettsville has a 24-bed semi-private. Yoakum Nursing and Rehab has a 20-bed semi-private. And Whispering Oaks Nursing and Rehab has a 14-bed semi-private facility as well. Devereaux, most of you that have been in this area any time know about Devereaux. I talked to them for a little while, and they don't really specialize in Alzheimer's care, but they do provide long-term care for mental health patients based upon the individual assessment of those patients and needs. They are a nonprofit behavioral health organization. They specialize in the treatment of youth and adults. And the one funny thing that I found from talking to them is they said that the referrals, they don't really get many calls because most people see them as a behavioral health, not a mental health. They do have an adult mental health side of their facility. Half of their campus is for adult mental health, and they do and are able to care for the Alzheimer's or dementia patients. They can focus on the care and treatment of behavioral health associated with the Alzheimer's. What they see referrals for more than anything they said was that they get the referrals once the behavior becomes the most significant part of the Alzheimer's disease in a patient. Psychiatric home health. I'll be really honest with you, I had never seen this before I came to Victoria. I didn't even know this existed, and I was really glad to see it. Carter's Home Health, they provide home psychiatric care and assessments, a 24-hour Medicare credentialed nurses, a 24-hour on-call psychiatrist, prevention of hospitalization and ER visits. They promote home safety and fall prevention and schedule visits with psychiatrists. And I will tell you, as far as my facility and my personal belief, I think this is the greatest thing for patients that are going home. The rehospitalization rate for patients that go home with mental health is about 75% if there's no interaction between the time of discharge and the time that they re-see their psychiatrist. And if we put this into perspective, you have an Alzheimer's patient, even early onset Alzheimer's, they go into a facility like ours. They have 24-hour care, they have people caring for them day and night, and they get accustomed to this facility. Then we take them or remove them, put them back in a different facility, they're already confused. We've just taken them out of one environment, stuck them in another environment that they don't remember because they have Alzheimer's. With Carter's Home Health, they can go in that home on a daily basis, evaluate that patient, see what's going on, and if there's something happening, they can refer them back to the hospital or back to an inpatient facility or come to us and say, can you help us, we need to find a resource for this person, that the home life is not working. Why psychiatric home health has not happened before, I have no idea, but this is the greatest idea ever for these patients. Outpatient services. There is an Alzheimer's caregiver group, support group at the First United Methodist Church every second Thursday from 3 to 4:30 p.m. There are also other groups, associations that provide services, group counseling, family counseling, and it's in that pamphlet that I made for the resources as well. But these were directly associated with Alzheimer's. Homewood residents, they also have a Alzheimer caregiver group, and on the fourth Tuesday of every month from 6 to 7 p.m. Gulf Bend is probably the greatest resource for group therapy, resources, referrals in this area as well. Local psychiatrists, like I said before, not that many to list, but they're in the resource manual that I made, and you can refer to that. The DTAR Intensive Outpatient Program. I am very excited to be standing here today to tell y'all that we are fixing to open an IOP. It's an Intensive Outpatient Psychiatric Program. It will be the first one of its nature in Victoria. We are in the process of converting the old ICU in DTAR North into this Intensive Outpatient Psychiatric Program. What this will entail is patients come to us that are 60 and older for a geri-ed program. It is a step-down program to going home. The patients can be referred to us. The patients come to us from 3 to 5 hours a day, Monday through Friday. We do group therapy with them. We do med counseling with them. We do education. The psychiatrist will see them. The social worker will see them. We deal with social issues. We deal with drug issues. And this will be a drug and alcohol program as well as mental health. So this will open March 1st of next year. And that's my resource presentation. Do you all have any questions? Yes, ma'am. Yes, ma'am.
Is there a cost for the warrants and the warrants?
The question she asked is, for the warrants, for the emergency detention warrants, is there a cost? And it's funny you asked that because we had kind of a battle with that here. There is no cost. The government, the local government, the county, and the city take that cost for all mental health patients. It's just a service that they provide. I will tell you, and the one thing that we will request of you, if you are coming from a different county other than Victoria County, and I'll be the person you usually talk to for the referral, or Patty, or social worker. If you refer a patient to us and I get certain data from you and I tell you that patient needs to come to us on an emergency detention warrant, I'm going to have you initiate that warrant from whatever county you're coming from to be transferred to us. And so that would be the only difference, but there is no charge. They're not charged for mental health warrants. Yes, ma'am.
The psychiatric home health, does Medicare, Medicaid, private insurance, do any of those three cover it?
Yes, we do.
All three? All three.
You're good.
Thank you.
Do you have any other questions?
We couldn't hear the question.
Oh, what she asked was for psychiatric home health, was it covered by Medicaid, Medicare, or private insurance, or private pay, and it's covered by all.
That's going to be decided by which home health. Because every home health is different.
Psychiatric home health is only one in Victoria. Yeah, Carter's is the only one that does psychiatric home health. There are other,
I just wanted to throw in, on the fourth Tuesday of every month, we do workshops with Hospice of South Texas based on Alzheimer's and dementia, so that's another.
so you're just showing me I didn't do my job.
No. No, I'd like to add to the presentation.
Did y'all all hear that? Tell me that again.
Okay, again. Come out from behind the board. On the fourth Tuesday of every month, we partner with Hospice of South Texas and do workshops on Alzheimer's and dementia. This last Tuesday, we have Meredith that will be speaking today, and she does, it's called neurobics and nutrition in the brain and different topics that are very helpful. So I just want to throw that in as a resource, and I apologize because when Robert asked me about information on us, I did not include that, so that was my fault.
Thank you.
And every once in a while, some of them have CEUs.
Okay.
So,
And those flyers are in your packet.
Any other questions? Yes.
The Lighthouse at Trinity Shores, where is that, and is it private pay, or does Medicaid pay?
It is private pay, and it is in Port Lavaca. The address is actually in this resources manual that's over there on the DTAR table. What is y'all's address?
201 Trinity Shores Drive.
201 Trinity Shores Drive in Port Lavaca. And I will tell you, it's a very nice facility.
It's on the back road.
Very nice
right?
facility.
Yes.
You had a question?
I'm at, sorry, I'm a public with Alzheimer's disease. Is that strictly Alzheimer's or is that all dementia?
That's Alzheimer's alone. Yeah. Quite significant. Any other questions, sir?
Would you comment as to what has been your experience to what can or cannot be done by the individual to deter, prolong Alzheimer's?
My answer is pretty simple, nothing. Alzheimer's, it progresses the way it's going to progress. There is no known cause of Alzheimer's at this time. There are medications that we utilize to help maintain the level of functioning, which is basically what we're working as from a medical standpoint, we're working to maintain the level of functionality because the mental capacity we know is going to decline. Oh, did y'all hear what he said? He asked me, was there any, repeat what you asked me again.
what has been your experience with regard to what can or cannot be done by the individual to deter, prolong this horrible disease?
He's asking what can be done by the individual patient to deter or prolong the effects of Alzheimer's, and again, my answer was pretty much nothing. Alzheimer's, there is no cure, there is no known cause. Basically, our focus again is for the functionality of the patient, to make them as independent and as functional in whatever setting, in the least constrictive or restrictive setting as possible. We do know that as the disease progresses, that the mind deteriorates, and that they're going to need further and further physical as well as mental health care. And that progression is pretty much consistent across the board for all patients. Which is why mental health should be more on the focus of everybody's forefront, in my opinion. Is there any other questions? All right, thank you all very much.